Okay, if we can get started again. What we're going to do now is then to look at the various diseases and the characteristics of these diseases. And we'll start off with the disease trachoma, again, caused by C. trachomatis, and the biovirus is biovar trachoma. What happens in this disease is, again, either because of chronic or repeated infections. Remember, we don't develop long-lasting immunity, so we can be repeatedly infected. If the eye gets completely, either chronically or repeatedly infected with this thing, what happens is we get the formation of these lymphoid follicles in the conjunctiva, and also fibrosis. As the tissue is damaged, you get more and more fibrosis. And what happens when you have all these lymphoid follicles and this fibrosis occurring in here, the eyelids turn in. And what happens is then every time the person blinks, the patient blinks, the eyebrows scratch the cornea. And you get the constant scarring of the cornea as the person blinks because of this interning of the eyelid. Eventually, you can get tears in the cornea, and scarring of the cornea can occur, and also blood vessel formation in the cornea. And in addition to that, the flow of tears can be impeded because of the infection, which then makes the patient susceptible to secondary eye infections. And so all this damage being occurred to the cornea, as well as any secondary bacterial infections or any kind of infection of the eye, ultimately results in scarring. And as I said, this is the number one cause of blindness. Now, I guess I should point out, some people came up in the break and said, well, we heard it was vitamin A deficiency. I should restate the thing. This is the highest, the leading cause of blindness caused by an infectious agent. Okay. And again, but this is not one that you see in this country a lot. I don't know if you can see this. If you can see these little follicles on the conjunctiva of this eye, and again, they're just you constantly scarring of the cornea is what ultimately leads to blindness. Now, there is a milder form of an eye disease called inclusion conjunctivitis, caused by the same organism, same biovar, the trachoma biovar of C. trachomatis. And this one is typically associated with the genital chlamydia. And what this disease is characterized by a mucopurulent discharge in the eye. And there can be, in more serious infections, there can be infiltrates into the cornea, vascularization and scarring of the conjunctiva, the cornea can also occur, just like we saw in trachoma, but it's not as common, all right? But if it's left untreated, it can probably lead to that. But it's a much milder disease and typically doesn't result in blindness. And what this is primarily seen in neonates. An infection occurs by being born through a contaminated birth canal. And what you typically see is a week or so after birth, the child comes down with a mucopurulent discharge from the eye. It's not uncommon to see also in the same individuals rhinitis and also ear infections. Okay, and so if you see a newborn, if you see this occurring in a newborn, suspect chlamydia infection. Okay. But as I said, it's a milder disease, and it typically doesn't result in blindness. This organism can also cause in infants a pneumonia, and it's the same thing. It's the genital chlamydia that are doing this, and we get the child gets infected by being born through a contaminated birth canal. And what you see in this one is a wheezing cough and pneumonia, but typically there's no fever associated with this. And oftentimes in the infants that come down with pneumonia, preceding the pneumonia was actually some sort of a conjunctivitis. So that inclusion conjunctivitis can ultimately then result in the development of pneumonia. So if pneumonia in a newborn, particularly if there was conjunctivitis preceding pneumonia, again, suspect chlamydia as the source of the infection. Okay. There's an ocular form of this lymphogranuloma venereum. Obviously, this is now the LGV biovar that's causing this disease. And this obviously then associated with those serovars that are in the LGV biovar. And this is basically characterized by the conjunctivitis, a typical conjunctivitis like we've seen before, but with an associated lymphadenopathy. And the reason there's a lymphadenopathy, it's the LGV biovar is the biovar that infects macrophages. And so there's the draining lymph nodes will develop lymphadenopathy. All right. So you see conjunctivitis with lymphadenopathy. And that then should suspect lymphogranuloma venereum as the infection. All right, those are the eye infections. The urogenital tract infections. And now, again, we'll go back now to the trachoma biovar. Again, remember, this was the biggie, the number one STD. Now, in females, as in a lot of sexually transmitted disease, most females are, in fact, asymptomatic. And this is, of course, is a major problem. But this can lead to cervicitis, urethritis, and salpingitis. It's also is associated with postpartum fever. And also, in females, particularly since they're asymptomatic, there's a much higher increase in the rate of premature delivery and also ectopic pregnancy. So it's a major problem that females are primarily asymptomatic. Among males, of course, as again in most STDs, most males are symptomatic. So you're talking about 75% of the males are symptomatic, and the symptoms include urethritis, dysuria, and pyuria. This is the major cause of non-gonococcal urethritis, right? And it's also the major cause of what is referred to as post-gonococcal urethritis. And the scenario is this. The patient comes in complaining of urethritis. And so you take a swab from the exudate and you make a slide and you look at it and you see gram-negative dipococci, and you say, this guy's got gonorrhea. So you give him some penicillin and you treat him for gonorrhea. And he goes home, and a couple days later, he comes back, or 3 or 4 days later, he comes back. He says, well, I felt a little bit better for a while, but I'm having these symptoms again. And so you take another swab and you mount and make a slide and you look at it and you see lots of PMNs there, but you don't see any bacteria anymore. Well, what's happened? You treated the gonorrhea and you cured the gonorrhea with the penicillin that you gave him, but penicillin is inactive against chlamydia. And so you haven't treated the chlamydial infections. And most people that have STDs, if they have one, they're likely to have others. And so they come down with post-gonococcal. If you only treat the gonorrhea, there's a likelihood that they're going to come back with post-gonococcal urethritis, which is caused by something else, usually the chlamydia, because this is the major STD. So typically, of course, what's done, if you treat for gonorrhea, you also treat for chlamydial infections. And penicillin is not effective against chlamydia. Here it just shows you a time course in infections in males. We're looking at the percentage that are showing symptoms. And you can see about 75–80% develop symptoms, but they will ultimately subside, even in untreated cases. But there's always a portion of even in the male population that are asymptomatic. And this is, of course, the problem why it is difficult to control this disease. Because women are asymptomatic, and a certain proportion of the men are asymptomatic as well. This organism also is associated with Reiter syndrome. Have you had Reiter syndrome before? Have you heard of it? This is that triad of symptoms: a conjunctivitis, a polyarthritis, and then some evidence of an infection, a bacterial infection. And the infections are either genital tract infections or gastrointestinal infections. Dr. Fox will talk to you about Reiter syndrome when he comes to the Enterobacteriaceae. But in a lot of cases, the infection that is associated with this syndrome is actually a genital tract infection, and it turns out that a large proportion of those are chlamydial infections. In fact, again, this typically is seen in people that are HLA-B27. But about 50% of the patients with Reiter syndrome actually had their evidence of infection was actually a genital tract infection with chlamydia. And if you look at it by antibodies, it's even higher. 80% of the Reiter's patients have antibodies against chlamydia, suggesting a prior infection with chlamydia that may be contributing to the Reiter syndrome. All right, the next disease is lymphogranuloma venereum, caused by the LGV biovir of this organism. And this occurs in a couple stages. The first stage, there's just a small, painless lesion at the site of the infection. There may be some fever and headache associated with this, but it's typically not, you're not likely to see the patient at this time because it's a small lesion, it's painless, and most people will just ultimately ignore it, and it goes away, and they think that they dodged a bullet. All right? And then the second stage comes in. And in this stage, there's inflammation of the draining lymph nodes because, remember, this is the organism that infects macrophages. So the draining lymph nodes get infected. And there's fever and headache associated with this. And these lymph nodes get very, very enlarged. And they're called, ultimately, they're called buboes. These large lymph nodes are referred to as buboes. These things can get so large that they actually rupture and drain. And I'll show you a picture of some in a second. Rupturing of these things can result in proctitis. They also can block the lymph system so that there can be elephantiasis of the genitals and ulcers in the genital area. So these things get very, very large. And I think I got this picture. Can you see them? The inguinal lymph nodes here? Large, swollen inguinal lymph nodes. And so that's characteristic of this disease. All right. So those are the diseases. How can the lab help you diagnose this disease? All right, cytology. This can be helpful, but it's not particularly sensitive. And what I mean by cytology here is, remember, these are intracellular organisms. So you can take a scraping of the tissue. It's not sufficient to just take the pus or the exudate, because remember, these are intracellular organisms. They're not going to be found there. You've got to get the cells. So you've got to take a scraping of the tissue, and you can stain the scraping then with iodine. And the reason that you stain with iodine, those inclusion bodies that are in these cells, these infected cells, actually accumulate a lot of glycogen. And if you remember back from your biochemistry, glycogen will actually stain with iodine. And so you stain the cells with iodine, and you look for these inclusion bodies. The reason it's not very sensitive is that it's really difficult to find in infected tissue these inclusion bodies. They're not every cell that you get in your scraping is necessarily going to have it. So if you see it, it's good. But if you don't see it, it doesn't mean anything. Okay? The second way is by culture. And again, remember, these are intracellular organisms. Most labs, clinical labs, are not going to do this kind of culturing because this requires tissue culture. So this is going to be sent away to a reference lab. I think here in South Carolina, everything is, if you're going to culture for this, it's sent to DHEC, to the labs at DHEC, and they'll do this. And what they do in the culture is they actually take the tissue scraping that you send to the lab, and they will inoculate a cell line that is particularly sensitive to chlamydia infection. And they will infect that cell line, and then they will stain with iodine and look for these inclusion bodies. And you can see these inclusion bodies in the cells that are stained with iodine. And this is the most specific way, although this is now changing because now there are some DNA probes that we'll talk about shortly. So culture can be good, but again, it's not something you're going to get right away because you're going to send this off to a reference lab. It's going to involve tissue culture. It's going to take some time for you to get those results. There is an antigen detection kit, either an ELISA or immunofluorescence kit, and what you're looking for is a chlamydial antigen. Looking for antigen on the LPS is a way to get all the organisms. This is a group specific, so it'll detect all the chlamydia. If you get look for antibodies or look for the cell surface antigens, the outer membrane proteins, then you're looking for those various serovars. Again, this one is probably not one that's going to be done in any routine clinical lab. These would all have to be sent for reference labs. And it's not likely that you're going to really be worried about which serovar you're dealing with. You just want to know if you're dealing with this organism and treat accordingly. The serovar detection is primarily used for epidemiological purposes. So reference labs are going to do the CDC will be doing those kind of things. But they are available. Serology isn't particularly helpful. You can't distinguish between past or current infections. And remember, this is one that we get recurrent infections with, so we probably, have antibodies against these things. If you detect IgM antibodies, that could be helpful, but it's not something that would be typically done. It's just not particularly useful. Nowadays, there is a push to develop, and a number of different nucleic acid probes have been developed to detect this. And primarily because since the old way of doing it was the culture, and since that does take some time and it's hard, it takes a while to do, and only certain labs can do it. There's been a push to develop these probes, and these probably will eventually replace culture as the way of detecting these organisms. So those are the kinds of things that you can do. How do you treat it? Tetracycline, erythromycin, and the sulfonamides are the antibiotics of choice for these organisms. There are no vaccines. We don't develop immunity to them when we get the infections. So vaccines, there's no reason to try to develop a vaccine for this. And, of course, prevention, treatment, coupled with improved sanitation. And what's very important, obviously, safe sexual practices, but in patients that have this, it's important, the genital infection, it's important not only to treat the patient, but also their partners, because it's going to be passed on. So you want to treat the patient as well as all their sexual partners. All right, any questions on trichomonas? Yes? I'm not aware that there's a major problem with antibiotic resistance in these organisms. I think that they're treated with that group of antibiotics, and it's not a major problem. I may be wrong in that. Obviously, I don't treat these patients with this, but I have not heard that it's a major problem. Let's put it that way. Oh. Anything else? All right. The next organ is Chlamydia psittaci, or the old name Chlamydia psittaci. The cause of psittacosis, also known as parrot fever. It's called psittacosis or parrot fever because initially this infection was identified from a patient that got infected from a parrot. Parrots are psittacine birds, as are parakeets and things. So this is called either parrot fever or psittacosis. But in fact, this organism infects not only psittacine birds, it infects all birds, basically. And so sometimes you'll see this referred to as ornithosis, coming from the Greek from bird. This is an infection that we get from all birds, basically. Yeah, that's where it can be a problem. In fact, we'll talk about this is not occupational disease. All right, so where do we get this disease? We get this disease from inhalation of bird droppings. Remember, those elementary bodies are relatively resistant. If they're in the bird droppings, anything that disrupts bird droppings and aerosolizes these things, we inhale these bird droppings. Now, there actually has been person-to-person transmission has been documented, but it is very rare. Primarily, this is a disease that we get from inhalation of bird droppings. All right? And what happens after we inhale it, the organism first goes to the spleen and the liver and replicates firstly in the spleen and the liver. And there can be local then damage and necrosis in those organs. And then it spreads back to the lungs. Now, although it likes to go to the lung, keep in mind it can go to other organs as well. but it typically likes to go to the lungs. And you get this inflammatory, lymphocytic inflammatory response in the lungs. Okay, and so you get edema in the lungs, and you get this inflammation going on. Mucus plugs can develop in the lungs, leading to the pneumonia that you get. But again, this is one of this is one of those atypical pneumonias. It's not it's one that is a more milder form of a pneumonia. Yes. Well, obviously it's in the lungs, but then it makes its way into the blood to the liver, where its first replication goes on, and then it seeds back to the lung again. So it does, obviously it gets into the lung first, and then spreads to the liver and spleen, and then back to the lung. Okay? Now, again, this is not a common infection. When you're going to see chlamydial infections, you're going to see chlamydia trachomatis, and you're going to see the genital tract infection. That's the one you're going to see, because that's the most common. But there are some cases in the United States. We're talking about 50 to 100 cases a year, roughly. And of course, the infection comes from birds. The birds can be symptomatic or asymptomatic. And so any of the tissues from the birds, the feces, of course, feathers get contaminated with feces, and so this is the source of the infection, basically. So it's an occupational disease. Where you see this is veterinarians, poultry workers, zookeepers, pet keepers. This is where you're going to see the disease. So this is where a good patient history is going to give you a clue as to what might be going on, all right? So anybody that works with birds, you can begin to see, and comes down with a pneumonia, you have to consider the possibility that they're dealing with parrot fever or psittacosis. Okay, here's the time course of an infection in an uncomplicated. Again, remember, this is one of these atypical type pneumonias. What you see is, obviously, after some period of incubation, you get the onset of symptoms. And the symptoms include fever, chills, this non-productive cause, a mild pneumonitis. So you get the onset of symptoms after about a week or so, a couple weeks of infection. Again, the timing will depend on the bolus of the infection, obviously. And then it just recovers. The patient recovers, even in untreated cases. It's uncomplicated. It's a mild atypical type pneumonia. But remember, this organism can also see to other organs besides the lungs, so there can be some additional complications. And in the complicated cases, the time course of the disease is much longer. In fact, you see the incubation period and then the onset of symptoms. And the symptoms can be more severe, and it can include other organs. There can be jaundice, there can be mental confusion, and so on. And then it ultimately also recovers. It just takes a lot longer in a more complicated infection. But patients recover. Mortality rates are less than 5%. Okay? But it's just a much more prolonged disease. And so what do you do to diagnose it? Serology. Looking for there's a complement fixation test for antibodies, but again, you're going to have to look at paired samples in order to look for the rise in titer of the antibodies. And the treatment is tetracycline and erythromycin. Sulfonamides are not active against psittacosis or C. psittaci, only against the trachomatis. And the way to try to prevent it, things that are done, is quarantine of imported birds. Anytime any birds are imported into this country, they are always quarantined. And it's to help protect against this infection. All right, so we watch the birds. Again, the birds may not come down with symptoms. They can be asymptomatic, but at least you quarantine them for a while. You look to see if the birds remain healthy, and then you let them into the country. So all birds are quarantined. The issue of what about our poultry farmers and things like this, that's where the big issue comes in, because obviously the poultry industry likes to supplement their food with antibiotics to try to prevent infections in the birds. But that enters in this whole controversial area of should we be using antibiotics in food because this is also leading to antibiotic resistance. But that helps certainly contain the infection in birds, but it leads to other problems. And that's the way we basically are trying to prevent this disease. Okay, any questions on psittaci? Again, not one that you're likely to see, but keep in mind the occupational association. Birds, people that work with birds suspect chlamydia psittaci. All right, the last genus in the organism that we're talking about, Chlamydophila pneumoniae, the older name Chlamydia pneumoniae. This one is also called the TWAR agent. And the reason, and for a long time it was referred to as the TWAR agent. It's only within the last maybe 8 or 9 years that its name was changed. And it got the name TWAR because of this. There was an isolate of this organism in Taiwan, which was the TW183 isolate. And there was another isolate of this organism in this country, and it was called the acute respiratory isolate 39. But as these two isolates were being studied, it became clear that in fact it was the same organism, and so they then changed the name to TWAR. All right, so this became the TWAR agent. And for a long time we didn't know what the TWAR agent actually was, but then it was established that in fact the TWAR agent was a chlamydia, and it was a new species of chlamydia, so they gave it the name Chlamydia pneumoniae. And ultimately then, in the last 4 or 5 years, then this was changed to Chlamydophila pneumoniae. And again, it causes one of these atypical pneumonias. And then there's this association with atherosclerosis as well that we'll spend a couple minutes on. So what is the pathogenesis of this disease? This one is spread person to person. Okay, so this is primarily person to person spread in respiratory droplets. And it causes a mild pneumonia, but primarily it causes a bronchitis and a sinusitis. And then in some cases, it can develop into a pneumonia. Now, this is actually a pretty common infection. These are estimates, 200,000 to 300,000 cases per year. They're only estimates because we really, again, it's not a reportable disease, so we don't have good statistics on these things. So these are estimates. And it's primarily found in adults. And most infections are in fact asymptomatic, or if there are symptoms, it may be a mild bronchitis or sinusitis. And there's only a few people that will then ultimately go on to develop pneumonia from this infection. And it's associated with crowded conditions. So again, where do you see this? You see this in dormitories, on military bases. College campuses are a great place to have this disease transmitted. So that's typically where you see it, and anything associated with crowded conditions, it's easily spread in those environments. And then there's this association with atherosclerosis. If you take atherosclerotic arteries, you can actually detect the organism in the diseased arteries. Whereas if you take, even from the same patient, if you take a part of the artery that is normal, that is not diseased, you cannot detect the organism. And so this organism has actually been isolated from diseased arteries, but not normal arteries. In addition, if you look at patients with atherosclerosis and you look to see whether or not they have antibodies against this organism, there's a good correlation between the presence of antibodies to this organism and atherosclerosis. And so there was a lot of interest over several years ago to see whether or not this might actually be contributing to the development of atherosclerosis. And wouldn't it be neat if atherosclerosis was an infectious disease, because we can treat infectious disease. In fact, they did a number of clinical trials where they tried to treat patients with atherosclerosis with antibiotics. And the last time I checked into this, there really wasn't a very good outcome of those studies. So I think the jury is still out on whether or not there's any involvement of this organism in atherosclerosis. It's clearly in a lot of the diseased tissue. And what it's doing there, whether it's there causing the disease or exacerbating the disease, or whether it's there because the disease made a good place, disease artery was a good place for this organism to hide out. We really don't know. Maybe in the future it'll be clear, but it's not clear now. All right, so what does the disease look like? Again, in most cases, as I said, it's very mild disease or asymptomatic completely, and you can get a bronchitis, pharyngitis, cough, malaise, just very nondescript type symptoms. Okay, but pneumonia can develop in some of the patients, and when it does develop, it's usually just a single lobe is involved. Your diagnosis is going to be by serology, again looking for an increase in titer of the antibodies, fourfold increase in titer in a group of paired samples from the patient. Treatment is the same, tetracycline and erythromycin. Sulfonamides don't work with this organism either. Sulfonamides only work with C. trachomatis. And obviously it's difficult to prevent transmission and try to prevent this disease, since most people are asymptomatic or have very mild symptoms, and they're still infectious. This disease spreads. It's not possible to contain this disease at all. And there's no vaccine has been developed. Okay. Any questions about chlamydia?